when we're looking at pharmacokinetic activity, and that's really where most of the interactions take place in the human body with herbs and with drugs, it's primarily pharmacokinetic. So you can have a drug-drug interaction. Goodman and Gilman says that by the time you get up to 8 prescription drugs, there's essentially a 100% chance for a drug-drug interaction. Essentially, you're going to be having interactions. And I can tell you, many, many patients, by the time they're in their 60s and 70s, are on 6 to 8 medications. Now you layer in supplements and herbs and everything else, and dietary changes and diminishing half-life, diminishing function of their kidneys and their liver, you're going to be a setup for problems. So just to remember, drug-drug interactions, patients are far too over-medicated in this country. Drug-food interactions, I'm going to explore this a little bit more in detail, but I mean, it is our exposure to phytochemicals since ancient times that has actually driven our evolution of what we call drug metabolizing, or I would call xenobiotic metabolizing enzymes. They were, by our very interaction and interfacing with phytochemicals over millennia, our body has created and devised these amazing enzyme systems and efflux pumps to be able to get rid of things that are potentially toxic. It is those pumps, it is those enzymes that are actually responsible for most of the medications that we give people, how they are metabolized. So drug-food interactions certainly occur as well. Drug-supplement interactions, drug-disease interactions, somebody has kidney failure, somebody has liver failure, somebody has heart failure, people who have fat absorption problems, so celiac with gluten, or with Crohn's disease, or inflammatory bowel, cystic fibrosis, pancreatic insufficiency. All of these things that alter GI absorption and elimination can also cause drug interactions. Pregnancy, a lot of people forget that when a woman is pregnant, she's actually revving up some of her systems that are able to metabolize xenobiotics, and it also reduces some enzymes that are responsible for ridding things. CYP1A2 is the big one for tobacco smoke. Has the opposite effect. When you smoke, you really rev that enzyme up. When you're pregnant, you lower it. And that can have implications for medication as well. And then the genetic polymorphisms that I mentioned earlier, there are tremendous genetic differences in how we're able to metabolize medications. And I'll talk more about that in just a moment. This is just a graph to remind us that as we get older, our ability to clear medications or phytochemicals or other things diminishes, and the half-life increases. So if you look at this graph, you can see in a young, healthy adult, at 1, they have pretty good clearance and half-life. As they move up to 60, you can begin to see somewhere around a 20% reduction in clearance of the drug. Half-life is not really changing too much. When you get up into that 70-year range, the half-life of the drug is now increasing somewhere around 30%. Clearance is diminishing. When you get to 80, you see this great variation. Now, I caution you to, it looks like, when you see the age going up, that, the clearance and the half-life come down dramatically. That is probably an aberration in the study. If you read the paper, it talks about the fact that there were so few 90-year-olds in this study that they were doing when they were looking at clearance and half-life, that they think that this is like an outlier, just so few people that it skewed the data. The driving point I want to make here is when you look at somebody who's 80 years of age, that half-life of that drug is greater than 50%, 60% more than it is. It's going to remain in their bloodstream so much longer, and their ability to clear it is about half what it is when they were young. This is why we have to be so thoughtful with medications. They need much smaller doses. Oftentimes the doses have to be spread out so that they're not taken as frequently. But we have to be thoughtful about that also when we're prescribing anything to an 85-year-old, herbs or otherwise. We have to be thoughtful about the fact that their ability to clear through their kidneys, for their liver, and also for their CYP enzymes, that all of these become altered with age. So just to think about that as we move forward. So when we're looking, this graph that we tried to create here was basically just to try to put into perspective what's going on. As I mentioned, we co-evolved with plants and other mammals and herbivores. And, you know, plants are stationary. I mean, their seeds scatter through the wind and birds and pollinators, but they're stationary beings. And when the herbivores come and eat them, they have tried to come up with defenses to discourage that, right? So they want pollinators to spread their seeds, but they don't want to be all consumed before they have a chance to reproduce. That's just the nature of life. Well, we, like other mammals, created ways to get around their secondary plant metabolites. And so these plant metabolites, or these phytochemicals, they kept concentrating them, which also is, we exploit these for dietary sources for health. We also exploit them in medicine, for herbal medicine. And by consuming those phytochemicals, all of life, plants, bacteria, viruses, fungi, mammals, birds, fish, you name it, all of life have these types of enzymes and pumps within them to be able to get rid of things that aren't healthy for them. So in our body, the ones that we talk about the most are the CYP enzymes, so cytochrome P450 system. The P just, you know, C is cytochrome, and then the P just really is referring to pigment, right? I mean, so these are heme proteins. They're hemoproteins, so they're red. And so the cytochrome P pigment 450, and 450 is just a wavelength. So it's looking at the wavelength of absorption of this when it's in the reduced state. So that's all that means is CYP 450. Those are enzymes that are involved principally in what we know as phase 1 metabolism or detoxification. So you're all familiar with this. These enzymes, they catalyze the oxidation of all kinds of organic substrates in the body: lipids, steroids, xenobiotics, drugs, toxins, phytochemicals, you name it. And these are responsible for the vast majority of the medications that we take. They're metabolized through these different P450 enzymes. You'll see on the left, and I apologize, it's kind of hard to tell in that yellow, those are the Pglycoproteins. So these are drug efflux pumps. Now this is actually quite cool. We didn't know about these until the 1970s in humans, but their job is basically to enhance excretion or prevent absorption of things that are toxic to us. So here you'll see it says drug, but it could be anything, any kind of xenobiotic, and it's in the intestine. And you've got these little efflux pumps that are in the wall here. And if it's something that your body doesn't want, these efflux pumps basically are just pumping these back into the intestinal lumen and sending them out in your feces so that you're not absorbing it. Now, you don't have these just only in your intestines. You've got them in the tubules in the kidney so that we can help get rid of stuff in the kidney through the urine. They're in your liver so that you can excrete them in the bile. They line the blood-brain barrier so that you can keep things that are toxic from getting into the brain. So these are actually these are quite interesting pumps, and they also are what account for like antibiotic resistance in many cases and cancer drug resistance, because you can have tumor cells that'll pump the chemotherapy drug right out of that tumor. and you've got bacteria that'll pump the antibiotic right out of it so that it can't harm the bacteria. So these pumps are quite fascinating to me, and again, many things in life have them, but they were designed essentially to protect us from toxins in the environment, which include many phytochemicals in plants. So plants interface with all of these enzymes, and there's more. These are the ones we're going to focus on tonight, but these are the primary ones that are responsible for interactions with drugs. So let me go back for 1 second also, just to say, you know, one of the things with like Pglycoprotein is if you inhibit that pump, sometimes you have to think backwards a little bit, but if you inhibit that pump, like in the intestine or in the kidneys, what happens when you inhibit Pglycoprotein is that you increase absorption, right? Because now it can't pump it back into the intestine. You're pumping it up into the bloodstream. If you inhibit it in the kidneys, then you're keeping it in the bloodstream longer because you can't excrete it in the kidneys. So these pumps are basically, they're efflux pumps. So they're trying to get rid of things, meaning they're trying to get them outside the body, either through the urine, through the bile, or through the feces. So when you inhibit those pumps, you increase absorption and you decrease elimination. That'll be relevant as we move along. I just wanted to make sure that, because sometimes that seems a little counterintuitive for folks. So pharmacogenomics, you know, this really throws the monkey wrench into everything. You know, it's like once we think we figured out those CYP enzymes and we got those Pglycoproteins down and we figured it all out, well, then we start finding out that people have tremendous variation in their ability to metabolize substances. So pharmacogenomics is really the study of how genes affect our response to drugs. This is a relatively new field. It's growing, you know, by leaps and bounds all the time, but it is relatively new, and we don't routinely test people. So we don't know how they're going to react to certain medications, and that could be very relevant, especially when it comes to severe adverse effects and why some drugs seem to work well for some patients and how some drugs don't seem to work at all. We used to not really understand that, and today we're learning that a lot of this comes down to our genetic makeup.